So this second half, we're going to be talking about we're focusing on ulcerative colitis. So we'll first start with Dr. Russell Cohen, and he'll be discussing our newer small molecules that we have available for ulcerative colitis and how we're going to be positioning them. And then we'll be following that with a case. We'll be hopefully addressing two cases, possibly one, where we're looking at various different therapies in ulcerative colitis. And then last, we'll be talking about Dr. Regueiro will discuss medical home and kind of an integrated approach to our IBD management. Okay, so we'll be starting with Dr. Russ Cohen.
Wonderful. Thanks for coming back and joining us. My disclosures have not changed in the past 20 minutes. So many of you are very familiar with the biologics, the biological agents. They're listed here, Crohn's and colitis, and we're hopefully going to have another biological agent approved soon. In addition, though, starting a few years ago, we moved from biologics to include now novel small molecules, and their small molecules are basically pills. So if you happen to be on Lipitor, or that's a brand name, sorry, Atorvastatin or aspirin, which is also a brand name, by the way, acetylsalicylic acid, you're on a small molecule already. But if they call it a novel small molecule, they can charge more money for it. And the two that families we're going to cover today are the JAK inhibitors and S1p modulators. So the Janus kinase or JAK inhibitors. So when we talk about the biologic antibodies, right, we're trying to prevent the antigen, let's see, TNF or IL-12 or IL-23 from hitting the receptor, either by blocking the receptor or blocking the protein. But what happens inside the cell if that receptor is activated? That is called signal transduction, and the JAK-STAT pathway is responsible for that. So as you can see in this cartoon on the right, you have the cytokine at the top, let's say IL-12, or hitting the receptor, and that activates the JAK-STAT pathway. And then the signal activation of the receptor is then transduced to the nucleus, and the cell produces the protein, whether it's IL-12, 23, or other mechanisms. They release more cytokines. There happen to be, I call this the Fantastic Four. There are 4 JAK inhibitors, JAK1, JAK2, JAK3, and no, that would make it that's too easy. Tyrosine kinase, or TYK2. So, and different antigens stimulate different types of different receptors are associated with different type of JAK proteins. So some of them are going to be used more so in oncology, and some are going to be used more so in inflammatory diseases, and there may be some overlap too. And you can see from this cartoon some of the different examples of what they do. So for example, JAK2 is involved with erythropoiesis. That's not something with IBD we'd want to block very much, but in certain hematologic conditions you might want to. Oh, look at this. I didn't even realize I had the cartoon. See, that you would have passed the test. So Tophacidanib is a pan-JAK inhibitor. While it does block all the JAKs, preferentially it's JAK1 and JAK3. Currently, it's on the market for multiple indications. There's a 5 and 10 milligram tablets available, dose BID, and there's an XR. So 5 plus 5 equals 11, and 10 plus 10 equals 22. So if any children are in the audience, I've just ruined your life. And more recently, it's available in oral solution. It's designed for pediatric indications in that way. However, obviously, if you have patients who can't swallow pills, there is an oral solution available. The main ulcerative colitis trials for induction, i.e. getting people well, are called the Octave trials. This is week 8. The drug is in red. Placebo is in gray. Yeah, Miguel, you got to put the placebo in gray in your slides, because that's like standard stuff that I said. Anyway, placebo's in gray. You can see clear benefit over placebo with both of these trials, which were nearly identical trials. And then maintenance, you want to sustain maintenance, so they called it the Octave Sustain. The placebo is in gray, as it should be. The 5 milligrams twice a day is blue, and the 10 milligrams twice a day is in red. The dose we start with induction in ulcerative colitis is 10 twice a day, and then if patients do well, we go down to 5 twice a day. In the rheumatoid arthritis population, it's typically just 5 twice a day. What about patients who had TNF exposure? So on the left-hand side, that's the octave 1, doesn't matter. Placebo, again, is in gray, and the drug is in red. So the left-hand side of the left-hand graph are patients who had TNF exposure. The right-hand side, those who didn't. You can see that in both cases, the drug does beat placebo. It works better in TNF naive, just like everybody else. But the point is that it does work in TNF failed, exposed or failure patients. Earlier, we had talked about the benefit in Crohn's of ustekinumab in TNF failures. Here, there's data for Tophacidanib and ulcerative colitis. Mucosal healing also is better. It still works in patients who are TNF exposed, which is the left-hand side of these slides, versus not on the right-hand side. The safety data is excellent. There's similar to placebo for infections, serious infections, less than 1%. However, we found out that the patients get zoster, right? The 5.6% at the higher dose. Luckily, as this drug was coming to market, the recombinant zoster vaccine started to use a brand name, Shingrix. It became available. We weren't allowed to use the live attenuated Zosterix vaccine, so please vaccinate all your patients with the Shingrix vaccine. Malignancy rates are similar to placebo, slightly elevated risk of non-melanoma skin cancer, but it's very slight. It does slightly change lipid profiles, but not known to have major issues. And then if you look at the main labeling, there is no known cardiovascular impact, and we'll update this, and reversible upon drug discontinuation, which is nice. So you can stop it and then restart it. Unlike a biologic, there's no issues of immunogenicity. And right now, we're advising pregnancy with any of the small molecules until we get more data on them. Due to a rheumatoid arthritis trial in patients 50 years or older with one or more cardiovascular risk factor that the FDA had asked them to the company to run. They did update the label about, and particularly, they did find higher rates of cardiovascular events, death, myocardial infarction, stroke, and pulmonary embolism. However, the analyses of the ulcerative colitis patients at the 10 milligram dose, this was the most common dose that caused these problems, was not seen even retrospectively in the UC population. Unfortunately, it changed the labeling both here and in Europe, where now to get to the JAK inhibitor, you have to fail or be intolerant to an anti-TNF first. Okay. And that's just because in the RA trial that I mentioned, their control arm was adalimumab, and the adalimumab patients had lower rates of cardiovascular issues as well as thromboses. So that's the label, that's the rule right now. And that actually has been extended to the other JAK inhibitors as well. So it's approved in adults for moderate to severe ulcerative colitis who have inadequate response or intolerant to anti-TNFs. And we do not recommend you use it in combination with immunosuppressants. And I recommend you stop azathioprine or 6-MP prior to giving this by a few weeks, because we've had problems with patients dropping their counts. In the rheumatoid arthritis literature, they do allow this to be given with methotrexate, but I probably wouldn't do that in UC since the methotrexate data isn't very good anyway. So right now, it's effective in UC. The Crohn's trials failed, so we don't use it in Crohn's, and the insurance usually won't pay for it. We try to induce at the higher dose and then maintain at the lower dose, although many of your patients might need to stay at the higher dose. You do monotherapy only. You vaccinate against shingles, and you basically ask your patients, do you have a history or high risk for pulmonary embolism, DVT, and if the patients are over 50, if they've had cardiovascular risk factors, you might want to choose something else, at least initially, although certainly doesn't prevent you using this or other JAK inhibitors. There are a couple of other JAK inhibitors on the market. The one we're going to talk about next is Eupatisitinib. The company that makes it submitted to the FDA in September for approval in ulcerative colitis. I'm going to quiz you on what this slide says. And their initial notification date is March of 2022, which is where we are right now. This is the Eupatisitinib, which is a selective JAK1 inhibitor, so it's a little different than Tophacidanib, perhaps. It's more selective, which may be better, maybe worse, maybe, maybe safer, maybe not. Anyway, the drug is in maroon as the University of Chicago colors. Their mascot is, by the way, are the Maroons. And the placebo is in gray. You can see clinical remission, response, endoscopic improvement, histologic, endoscopic, mucosal improvement combined. Everything clearly beats placebo. This is at the 45 milligram dose, which is what applied for approval. I want to point out that the RA dose on the market right now is only 15 milligrams. So the only way to get to 45 right now is 315s, because I did that math really fast. And then this was a similar trial as well, too. I'm going to ask you to read all these slides, but again, the adverse event profile was pretty good. There are slightly higher rates of infections, and we do recommend, again, zoster vaccination. Some minor lab changes that you might see, elevated CPK, which we're not quite sure what it means. It doesn't seem to correlate with any other outcomes. And you always have to, just like other immunosuppressants, you have to look for lymphopenia, leukopenia, getting CBC differential, LFTs, usually when you start, and then a month out, you check lipid profile before starting as well, too, and afterwards. Here is the maintenance data with Eupatisitinib. The placebo is in gray. The 15 milligram dose is in orange, and the 30 is in blue. You can see that blue and orange, each of them clearly beat placebo. Blue does seem to be higher than orange. We'll see what happens with the approval for the dose when it comes out. Presumably it will. Again, safe drug, slightly higher rates of nasopharyngitis, the CK elevations. The malignancies were spread evenly across the placebo group and the drug group. There was only one, there was an ovarian vein thrombosis in a patient who got placebo, 2 PEs in 15 milligram and 2 DVTs in the 30 milligram group. Most of these patients had risk factors, major cardiovascular events, one in placebo, one in the group, one perforation, but it was in placebo and no death. As I already mentioned, I'm not going to read this all to you, but the FDA extended the label warnings for JAK inhibitors from Tophacidanib to the other JAK inhibitors. Initially, they didn't, but then when more data came out, you can see updated January of this year, they extended that. So you do want to be careful about using these medicines in smokers, current or past smokers, those with known cardiovascular risk factors. And again, you have to go through a TNF first before you go to a JAK inhibitor, and that is unlikely to change. So this is what we think will get approved. Induction at 45 milligrams, clearly beat placebo in all the outcomes I listed. Maintenance, 15 and 30 both beat placebo in all these outcomes. I do want to point out that our specialty pharmacy has successfully been able to get Eupatisitinib at these doses off-label for severe ulcerative colitis, moderate to severe, and even moderate to severe Crohn's disease. There are Crohn's trials. If it does get approval, it won't be for a couple of years, but we've actually been able to get it. The insurers are paying for it because the data is there for Crohn's too. So that was one family of small molecules. The other one are the S1p modulators. S1p stands for sphingosine-1 phosphate. There are different receptors for that, and the idea is that it, by causing internalization of the receptors, you prevent the lymphocytes from leaving the regional lymph nodes in the gut, and it doesn't seem to involve protective immunity otherwise, since these cells don't otherwise circulate. There are 5 different S1P1 proteins. They have different mechanisms, and they're ones that are coming to the market. Competitors may be different in which ones they affect. They've been on the market for multiple years, since 2010 for MS, and in the Ozanimod was approved for ulcerative colitis in 2021. Again, being consistent, I keep the gray as placebo, the blue is the drug. You can see remission, response, endoscopic improvement, and mucosal healing all clearly beat placebo. This is 1 pill a day. It was less impressive in induction in anti-TNF treated patients. Most of the outcomes on the left-hand side, which is prior TNF, were similar to the blue, was similar to the gray, except clinical response was better in the drug. than naive. However, I'll show you in the maintenance data, it didn't matter if you were on TNF or not, if you had previous TNF or not. The results were excellent in patients who are TNF naive or TNF responders. So it turns out that if you respond to Ozanimod, it seems to work well in maintenance as well, too. Histologic remission also better in the drug in blue than placebo in gray. The extremely safe drug, the adverse event rates were similar to placebo. So luckily, with the labeling, patients with moderate severe ulcerative colitis do not have to fail conventional therapy at all. It's 1 pill a day. It's 1 milligram. It's the same dose for MS as it is for ulcerative colitis. It's contraindicated if you had a recent cardiovascular event, TIA, heart failure, or if you have known heart block, untreated sleep apnea. You can't use an MAO inhibitor with it. There's a dose pack when you start therapy that, while it's still 1 pill a day, the pills are smaller doses, but it comes in a dose pack. So you start them on the dose pack, and then they go on to the regular 1 pill a day. So in summary, JAK inhibitors are effective in moderate severe ulcerative colitis. You have to fail anti-TNF at first. And we're hoping that Eupatisitinib will join Tophacidanib. And as I mentioned, we've been able to get Eupatisitinib even approved at the higher doses for Crohn's off-label. S1p inhibitors, you don't need to fail anything. Ozanimod, 1 pill a day, FDA approved for ulcerative colitis. And with that, again, we'll stop early because you didn't think I was going to make it. And thank you for your attention.
Okay, thank you, Dr. Cohen. So we'll go on to our next case, and we'll be thinking or talking a little bit about some of our current small molecule therapies in ulcerative colitis. Okay, so we'll get started. All right, so for this case, this is a 52-year-old male. He has a history of ulcerative colitis that's left-sided, diagnosed in 2010. At that time, when he had his presentation, he was started on steroids and transitioned to mesalamine 4.8 grams a day. He had his follow-up colonoscopy in 2013, so a little bit not exactly treat to target at that time. So the mucosa did show some decreased vascular markings, increased granularity, and shallow ulcers in the rectum and sigmoid with a cecal patch. Otherwise, the colon looked normal, and the terminal ileum also was fine. So between 2013 and 2018, he maintained on mesalamine 4.8 grams and turmeric 3 grams a day. And he's had no symptoms at this time and did not really want to pursue any further colonoscopic evaluations. And in 2019, he had not sat out care for several years, but he had to be switched over from insurance from 4.8 grams to mesalamine extended release pill 1.5 grams, and then he actually started to develop some increased symptoms with that switch that was mandated. In 2019, he says when he established his care, he noted having 4 to 5 loose stools a day with visible blood in every stool, no nocturnal bowel movements, no abdominal cramping, no joint pains, or any extraintestinal manifestations. So in 2019, he's able to get back on the mesalamine 4.8 grams, and his symptoms don't improve. Oops. Okay, so what are the notable parts of this history now that you'd like to highlight, and what diagnostics should we consider for him? So Dr. Limkakai, what are your thoughts right now on how he's been managed and what maybe could have been done differently?
Yeah, so certainly, so it seems like in 2013 he was found to have at least some endoscopic evidence of rectosigmoiditis. And while between 2013 and 2019 he's been feeling well, while on that combination of mesalamine and turmeric, we do not know, whether there was actually underlying inflammatory activity. And this is reflective of how, even as what was actually presented earlier, that symptoms don't necessarily correlate well with underlying inflammation. And what could have happened during that time course is that inflammation may have then persisted and progressed over time. And so while it's interesting that the 4.8 grams of mesalamine then being switched over to 1.5 grams was the trigger and yet not being able to achieve remission even after returning back to the 4.8 grams, there may have been something else or brewing inflammation that's just been progressing and now just triggered a flare. The other point I would like to add is that the mesalamine 1.5 grams is actually a maintenance dose, and versus the 4.8 grams, which is an induction and maintenance dose. So while he may not have needed an induction dosing, there was actually a difference in the concentration of mesalamine he was experiencing. And in terms of diagnostics, I think at the very least he probably should undergo a colonoscopic evaluation. A calprotectin would be helpful as well if you wanted to calibrate a stool test with what is found on a colonoscopy. And also stool tests to see whether there are other potential mimics of colitis, be it like C. difficile infections or any even other infectious gastroenteritis that may have driven his persistent symptoms.
Yep, so exactly. Have you guys seen these flare with that man? We've seen patients have to switch over to different mesalamine formulations due to insurance. Have you?
Well, it's not just the change, it's the dose.
Yeah.
Dramatic dose decrease. So to go to 4.8 grams, 1.5, you're essentially, cutting with 2/3 there, right? The dose. I want to point out that that formulation, which was known under the branded name Aprizo, was marketed only in the United States as 1.5 grams, which is 4 pills a day. However, there's much better data at 3.0 grams. And the insurances that have mandated the switch, if you prescribe 3.0, they usually will pay for it because, and if they won't, then you really have to fight them because they shouldn't be demanding that someone cuts the dose of their medicine like that.
That's actually really helpful. Yeah, so we had to fight for him to get back on a higher dose. So here's his colonoscopy. He has mild, moderate disease activity, mainly in the left side, and that same cecal patch. So kind of exactly what had been seen in 2013. And I'll probably give him a Mayo score, too, based on that. And he had a fecal calprotectin, 864, so it is elevated. No other abnormalities in his other labs. So he's not somebody who mounts a CRP, so that's probably something we can't really follow for him. So he ends up on mesalamine enemas daily with oral mesalamine. So there's data to suggest that combination of the two work better than just the oral. So he was on that before the colonoscopy, but still didn't have any improvement in his symptoms. So then he started on budesonide MMX, 9 milligrams, in addition to the mesalamine enemas and oral mesalamines. And his symptoms did improve while he was on the budesonide to no blood in stools with 3 to 4 bowel movements a day. And he remained on the oral mesalamine and the enemas. And he tried to taper off the budesonide MMX after 8 weeks with immediate relapse in his blood and his stool. So he restarts it again, this time around without much improvement. So he's certainly flaring more now and not responding to the budesonide MMX. So at this point, what treatment considerations do you have for him, Dr. Regueiro? How would you counsel him regarding his treatment options?
Yeah, so I think one thing to take a step back in ulcerative colitis, and we know this from some of the AGA pathways and other, really ulcerative colitis comes as either 5-ASA responders or 5-ASA non-responders. And something different than Crohn's, about 50% of your ulcerative colitis patients will respond to 5-ASA. So that is a difference between ulcerative colitis and Crohn's. The other part of this is that you've obviously added rectally administered 5-ASA, so you're actually giving oral and rectal, which I think is reasonable. He now is essentially budesonide or steroid responsive, but he's essentially dependent. So what are your options? And when you go through this with your patients, really you're looking at what's the next level above steroids at this point. You could put them on a different steroid. You could put them on prednisone, but you're long-term not necessarily going to make a difference between that and budesonide. So I'm not sure that's a great option. One thing I'll say that's very old school, I bet 99.99% of you wouldn't do this, but I do this in my own practice. I still think sulfasalazine plays a role. I realize that's somewhat controversial, but I have had patients where I've switched to sulfasalazine. But for purposes of now, let's leave that behind. I think this is a patient that then you're looking at what's the next level of treatment. So you have the oral small molecules, but as Russ said, at least Tophacidanib right now has to come after an anti-TNF. So you could do Ozanimod, or you have your biologic monoclonal antibodies, which right now are going to be Natalizumab ustekinumab, or one of the anti-TNF therapies. I think if you were to position him, he's not terribly sick, but he's just not responding to 5-ASA and steroids. To me, this is going to come down to vedolizumab or Ozanimod. It's going to be one of those two. I think Ozanimod's a very reasonable approach here. It's an oral small molecule, as Russ said. It doesn't require anti-TNF prior treatment. I think Veto is reasonable too. In the United States, currently it's only given intravenously. In other parts of the world, it's sub-Q. Hopefully we will have the sub-Q formulation at some point. But for right now, that's the only discussion I would have with the patient. So to me, it would be a discussion between Ozanimod and vedolizumab. If he were really sick, or sicker, I should say, then I would, my go-to first-line therapy for very severe, acute severe UC is still infliximab, and usually I do pair that with azathioprine. But in him, it would be Ozanimod or vedolizumab.
What about ustekinumab?
Ustekinumab's reasonable. I think you mentioned it earlier. There are some barriers as far as getting approved through insurance. It's not unreasonable as the first-line therapy. I think vedolizumab and Ozanimod to some degree seem to be better if you use them as first-line therapy, where if you fail an agent, then go to those two, they're not as good. Ustekinumab actually has shown pretty good efficacy even after anti-TNF, so it's not a reason to use ustekinumab second line. I'll also just be practically very honest with this audience. I've still, in pockets of Cleveland, had a hard time getting ustekinumab approved first line. And when we're going through this, I've been more successful with some of the other therapies. Probably the easiest therapy to get approved, if you were to look at it that way, but I'm not pushing for this as first line for that reason, is adalimumab. That's still, to me, that and one of the biosimilar infliximab agents. But in him, I think Ozanimod and Veto, but I couldn't argue if you wanted to give him ustekinumab.
Yeah. Dr. Cohen, would you do anything differently, or your thought process?
Well, you know, I asked the patient, I said, you want to take one pill a day, Ozanimod? Would you want to get an IV, week 0, 2, 6, and every 8 weeks, vedolizumab? Would you rather get one IV and then an injection every 8 weeks, ustekinumab? Most of the patients will, well, I should say most of the patients. Most of the patients I ask will just say, I'll take a pill. I'm already taking pills anyway. Many people find the idea of ustekinumab to be more convenient than vedolizumab, but I agree with Miguel in that it's not always gets through the insurance, although we kind of find out pretty soon. We don't always find out pretty soon. Still some insurance issues with that too. But no, I would not give adalimumab or infliximab in this individual right now unless I absolutely had to, because I think the other options are effective and safe.
Okay, great. So at the time, Ozanimod was not an option, but here he had a prednisone taper, then started vedolizumab, but he didn't really respond as well as we would like. So this is now 3 months into the vedolizumab, and again, he's starting to see blood in his stools with urgency without the prednisone. His trough level's at 10.2. This is at week 14. Then increase the vedolizumab to 300 milligrams every 4 weeks to achieve a trough of 17. He still could not wean off the prednisone below 10 milligrams, and his fecal calprotectin's at 392. And here's a sigmoidoscopy at that time, so he has chronic colitis with mild activity. This is super mild. So these are difficult cases. You know, this is prednisone avid patient, really, really loves his prednisone. Not that severe, though. So this is what's going on with him. He just he doesn't have a lot of severity, but still has activity that won't respond without some prednisone. He's 4 bowel movements a day, occasional incontinence, occasional blood and mucus, improved with hydrocortisone enemas. So I just wanted to ask a question to the panel. If you do utilize therapeutic drug monitoring in your practice for non-anti-TNF therapies, is that something that you do commonly? And if so, in this patient with vedolizumab levels of 10, do you feel that that would have been someone that you would have dose escalated? So Dr. Cohen, you're smiling.
So for non-anti-TNF agents, I rarely utilize drug therapeutic monitoring. The data does not support it. Patients who do better often have higher levels, but that doesn't necessarily mean that higher levels lead to doing better. Particularly with vedolizumab and even ustekinumab, it's very unclear actually what's going on with those drugs and levels. More so patients, if I'm wondering if they have antibodies, sure. If they made antibodies to other agents and things too, then I might check. But A, you'll almost never see antibodies to those two. And B, I think it's just, they get to convince the insurance to pay for them.
So would you have dose escalated to every 4 weeks based on clinical symptoms, or not necessarily even do that?
So with Natalizumab, I say to the patients, well, what happens? Do you actually, and you should talk to your patients, do you find that the first 4 weeks are better than the last 4? Some will say, they'll say that, well, medicine's working. It's not working at all. Well, how about when you get infused? Oh, yeah, that is great. I'm great for 4 weeks, 6 weeks, and then I start relapsing. Those are the patients where I would go to every 4 weeks. But the people who are like, nothing's happening, they're on it, you stick a scope in or get a fecal calprotectin, it's very high, you could go to every 4 weeks, but I'm skeptical that that's going to be the answer.
Okay. So what's the next management strategy? Dr. Limkikai, what would you do in a patient like this? You're on Q4 vedolizumab. He's not really responding, still likes his prednisone, still needs it. And did COVID affect your treatment recommendations? I'm curious.
Yeah, no, the great questions. So I guess what had been discussed earlier were the initial possible drugs to use for induction remission in this gentleman. Unfortunately, vedolizumab is not enough, and even with Q4 week dosing, which is the highest we could even get approved via the insurance, has been ineffective. So in which case, I think there's a time, once we've established that the medication is not working adequately, we would need to switch to a different agent. And, vedolizumab has natalizumab, it's something within the same class, but, in this case, in either way, we would actually switch to a different class. I would say this is where also anti-TNFs could also be then entertained as an option. And with regards to the question about COVID and whether it affects treatment recommendations, the fortunate thing is that at least based on, the evolution of data and what we have thus far, that the use of biologic therapy has not been shown to be adversely or significantly detrimental in the setting of this COVID pandemic. And we even published a recent systematic review looking at the use of the different agents and the risk of hospitalizations, escalation of care to the ICU, as well as need for mechanical ventilation and death. Unfortunately, have not shown a significant increase of the risk of those outcomes. Now, granted, there are of course different confounders. So in this particular case, I would still approach the patient as if COVID were not present. Nonetheless, sharing the caveats that we are in the pandemic, we need to also be very vigilant and careful about our infectious precautions. And if or when if COVID were to occur or to be infected, then we may hold the therapy just momentarily.
All right. Dr. Regueiro, what would you consider next for this patient?
Yeah, so, what are your options? I forget what year we're in now, but the options are going to be, again, Ozanimod, which may not make sense now because you're getting into 2 lymphocyte trafficking agents. They work a little bit differently. So I think it's an anti-TNF or Tofa. Now, the problem with Tofa, based on the label, it says specifically after an anti-TNF. Nonetheless, it's still something I wouldn't take off the table. Certainly right now, this patient's not sick enough for surgery, and I think if you mention surgery, you'd probably get up and leave your office because that's not where he is. So I think this is somebody, the only thing I will say is I'm getting a little bit worried. This is somebody who's gone through 5-ASA, steroid dependent, now on veto, now not responding. I want to get my next agent right, and I want to get this guy well, and I want to get him well quickly. Personally, I'd probably put him on infliximab in combination with azathioprine. I'd talk to him about how long we'd keep him on azathioprine, but I'd really try to see if we can get him better very quickly. If you don't use azathioprine, I would certainly use proactive monitoring, and I'd be not hesitant to bump up his infliximab. One final thing, I agree with Russ. I don't use veto or ustekinumab levels, but for the audience, based on the data, which we still do not understand, but if you are to look at targets, 4.5 for ustekinumab, 25 for veto. However, what Russ said is true. They have very low immunogenicity. We still don't understand the levels, but just to put that data out there.
Yeah, so I just summarized some of the studies out there, and it's a little bit different from what, see, the numbers are everywhere really, but we don't have a lot of good data on levels with other biologics outside of the anti-TNF therapies. Having said that, these are some of the data that I've seen, and in my practice, sometimes I will use it in a bind to try to really help me decide whether or not, someone might benefit from further dose escalation. So I'm going to move on. So I'm going to talk a little bit about positioning of therapies in ulcerative colitis. So I'm going back to our network meta-analyses that we talked about, and this time looking at moderate to severe ulcerative colitis in biologic naive patients. And in this case, in this meta-analysis, infliximab outperformed all the other biologic therapies and Tophacidanib. The next one that was considerable, had a considerable efficacy was vedolizumab or golimumab. And as I mentioned earlier, head-to-head clinical trials are very important, and there is one for vedolizumab versus adalimumab for biologic naive moderate to severe ulcerative colitis. And in this case, vedolizumab did outperform adalimumab in bio-naive ulcerative colitis patients in clinical remission and endoscopic improvement, but there was no statistically significant difference in corticosteroid-free clinical remission at week 52. Now, when we look at patients with prior anti-TNF therapy, patients at higher odds of clinical remission achieve that with ustekinumab or tofacitinib over vedolizumab and adalimumab. So I just wanted to present that data to you. And let's go back to our case. So he wants to try adalimumab. He doesn't want combination therapy. He's really afraid of infliximab, and this is during the COVID pandemic at the early times, and he just doesn't want any of the combination therapy. So he starts adalimumab, has 2 months after initiation, has urgency, cramping, still not doing well. Really, just not doing great with it. He's now ready to go to weekly with the azathioprine. Trough levels at 4.1. He's just not doing as well with it. Then we check the 6T-GAN, it's at 75, and on the weekly adalimumab, his trough levels at 8.7, antibodies at 3.8. So he does have a low level of antibodies. So what do you guys want to do with that presentation with this patient? So he has low-level antibodies to weekly adalimumab. That may not have been my choice for him, but this is shared decision-making, and he wanted to try that therapy next. What are your options at this point? Dr. Cohen.
Well, not sure what low-level antibodies mean in the presence of drug, because obviously if they were all neutralizing, then there wouldn't be any. His azathioprine dose is 50, which is a very low dose. It's a pediatric dose unless the patient happens to have genetic issues with metabolizing it. And his 6TG level is 75, while the analyses that Marla Dubinsky and others have done have shot for a goal of at least 235. So he's very underdosed on the azathioprine. So before, I think, skipping around therapies, you might want to try to optimize what he's on and go from there. There may be, with higher azathioprine, you might actually see those anti-drug antibodies go away. I don't know for sure because they didn't really look at that in some of the studies. They just looked at adding azathioprine to people who had antibodies, not necessarily going up on the dose. Before we had before we had adalimumab or infliximab, we only had azathioprine, but we didn't dose it at 50 milligrams. So.
Yeah. How about Dr. Regueiro? What are your thoughts?
Yeah, I think you have three options here, and I said it before. I think you wanted to get it right, and I know, Jenny, that probably wasn't your choice either. But now I'm getting more worried about him. So now he's on his second biologic therapy, not having the response we want. So now surgery comes in as a discussion. I don't think we're there yet, and I don't think he's probably there yet. But nonetheless, that's something to bring up. So the three options are optimize what he's on, which is what Russ said, switch to infliximab, apropos to your first case, even though his levels are starting to get better with adalimumab, or tofacitinib, you've opened the door. One thing Russ mentioned, also when you send levels off to the lab, know which lab you're sending it to, because LabCorp and Esoterics won't do necessarily a drug tolerant assay, which is what Russ was referring to, and you can get low levels of antibodies, quote unquote, with adequate drug. So different than some of the other labs, such as Prometheus. And I'm not being a proponent of any of them, but just to make sure you understand what that low level means, because low level's not always necessarily positive if it's not a drug tolerant assay. But in him, I would have a discussion between tofa and infliximab. and optimization. This is a guy I probably would start really talking about Tophacidanib if he's open to taking it twice a day. I don't hear any other risk factors in terms of clotting, so that's probably what I would go to next. I would have gone to Infliximab prior to adalimumab, but now that he's on adalimumab, I would do Tofa.
Great. So he's very reluctant to increasing azathioprine. He didn't want to do combination therapy to begin with. So we're at this juncture, exactly, the decision making. What do we do next? So actually, we decided to send there's this new assay, HLA-DQ-A105 assay. So there is a study that suggested if you have this risk gene, risk allele, that you may be at increased risk of having antibody formation to infliximab or adalimumab. Having this and knowing this, does that change your thought process on what you would consider next, Dr. Cohen?
Well, yeah, I mean, that's why you sent it. So it's the type of thing. Before you send a test, what are you going to do with the results? While we're not sure, the subsequent studies may not have shown this to be borne out, in reality, the point is that there is this genetic variant, and at least in some of the early studies, in a few different cases, it predicted antibody formation with adalimumab and infliximab. So if he has the variant, then that would make it less likely for you to go to infliximab. And also, if he's going to go to infliximab, he's going with azathioprine. So if he's not going to take it, then
Right.
it would make much more sense for you to consider having him go to Tophacidanib, because now he's been exposed to a TNF and failed, so he meets the criteria that's in the labeling, as we covered in my lecture.
Great. Okay. So that's exactly what the discussion that we had. And I'm going to go on to what we did next. So in April of 2021, he gets the recombinant Shingrix vaccine. He remains on low-dose prednisone 15 milligrams until he starts the Tophacidanib. And he starts Tophacidanib at 10 milligrams twice a day. He starts to taper off the prednisone, and he says it's the best he's ever felt, so I'm super thrilled. 4 bowel movements a day, no urgency, no blood in his stools. He doesn't come in for his colonoscopy in October, but by December, he's having bouts of blood in his stool with urgency and frequency improved with hydrocortisone again. So he still feels better overall with the Tophacidanib than with any other treatments, but he's not completely there yet. So how do you pre-counsel? Okay, we're going to go back to Tophacidanib now. How do you pre-counsel someone who has started Tophacidanib? I think Dr. Cohen has gone over a lot of the pre-counseling that we need to discuss with them. So I think we can go on that. If a patient, if he were a woman, how would you address preconception planning, and would you not have considered Tophacidanib in this patient?
Well, right now, all of the monoclonal biologics are felt to be safe in pregnancy. The quote old category was class B drug, showing that they do not cause birth defects in laboratory animals at high doses or in humans. The novel small molecules that are available, Tophacidanib and Ozanimod, are quote class C, so we generally do not advise pregnancy on them. There are patients who are getting pregnant on them, and so far the data seems okay, but you need a lot of patients before you can really make that clear.
Yeah, and so how are you handling that black box warning for Tophacidanib right now when you counsel your patients? And is there a population that you would not consider prescribing this medication to in light of that warning? And this will go for Eupatisitinib when that's available too. Dr. Regueiro?
Yeah, so I think Russ kind of pointed out. So one thing I tell the patients is you're going to read, or you may have already heard about the risk factor for venothromboembolism, DVT, PE, and now the cardiovascular risk. The other part, which Russ said during his talk, which I think is very important, is we have not seen this in our ulcerative colitis patients. So this is really our rheumatoid arthritis patients over the age of 50, and certainly the cardiovascular part, who have cardiovascular risk factors. So to answer your question, who would I not use TOFA in my ulcerative colitis patients, is if it is a patient who's had a DVT or a PE, or does meet the criteria for significant cardiovascular risk. So over age of 50, they've had an MI, they've had a CABG. One thing I will tell you, and this is, again, a little bit controversial, and I realize that we sit in maybe different centers than if you're in practice on your own. So what I'm about to say, I'm not necessarily recommending. I have had patients who've had DVTs that are provoked by their ulcerative colitis in the past, meaning bad UC is associated with a DVT. Their UC was treated, their DVT was treated. They have no other findings genetically or based on their lab parameters by the hematologist for a DVT. We think it's their UC. I have given them TOFA, but I've been extremely careful in letting them know that there could be an association. So if they get calf swelling, shortness of breath, I document it very carefully. But I have had successful treatment of their UC in patients who've had a prior DVT. If they have a protein CS anomaly or something like that, I would not use Tophacidanib in that patient. But that's usually what I tell the patients about the black box. We also counsel them on shingles. I think we're headed towards giving everybody Shingrix as a vaccine when they come into our clinics like we would Pneumovax. That's my personal opinion now that the age is down lower. But really that's it. The cholesterol part I mentioned, I'm not as worried about that, and I think Russ pointed that out already.
Okay, so Dr. Limkakai, when do you start that Shingrix vaccine? Is it important to initiate it before they receive that TOFA dose? Do you feel that they need to, does that delay their start of TOFA for you?
Yeah, so while we strongly encourage the administration of the recombinant vaccine, I don't necessarily use that as a gatekeeper for when they actually start the Tophacidanib, but again, we actually very strongly recommend that they start that, they get it earlier.
Okay, all right, great. So
There's also, I want to point out, you asked about COVID. The biggest risk factor for our patients is being on steroids for getting bad outcomes with COVID. Patients with IBD who are on steroids 20 milligrams or more are at higher risk for hospitalization, intubation, ICU, and death. The rates of those outcomes on any of the medicines we've talked about are actually very, very low, particularly for anti-IL-12-23, ustekinumab, the anti-TNFs, and even with Tophacidanib. So don't keep your IBD patients on steroids during a COVID pandemic. Get them on anything but steroids, anything else but steroids.
yeah, so that's what we've been trying to do with him throughout, but he's been unfortunately requiring it throughout his pandemic. And he has a colonoscopy, and he still has some mild activity in the sigmoid colon. That's really stubborn, 15 centimeters, still active. So my question to you, if he has only partial improvement, are you considering this a treatment failure? Did he fail TOFA, or is he okay? Do we keep him on this with hydrocortisone enemas periodically every 3 days? Are we done?
Yeah, so one, I'm assuming you did this, but this would be a patient that if he had not been on mesalamine suppository, I would definitely have done that. But let's presume that you've done that and that doesn't work, and now he's on the hydrocortisone. Again, it's a shared decision question and a discussion with him. I think hydrocortisone enema does not have, no, I'm using a double negative. It does have some systemic effect with steroids, so he has to know this. Another thing I've done, I have 3 of my Tophacidanib patients, again, I'm saying this, I don't recommend this to the audience, on tacrolimus suppositories have done exceptionally well, exactly this case with proctitis only. They've healed the rest of their colon with TOFA. It's the best they've ever done, but I can't get them off a low dose of steroid. Do I think it's reasonable to do the hydrocortisone enema every few days? If it's towards the point where at some time you will get them off the hydrocortisone enema, I have no problem, and I would probably give him a 6-month period of time. If you can't get him off the hydrocortisone enema, then I get a little bit worried, and then the question is, do you try another topical therapy, or is this truly a failure? I don't know if it is, but I have had some of these difficult proctitis-only patients on TOFA where they heal the rest of their bowel.
And if you use the tacro suppositories, do you use that indefinitely for your patients?
So I usually give about a 6-month period of time. Actually, 2 of the patients have had a really good response and have stopped their tacro. They're just on the TOFA 10 twice a day. And the other thing I'm assuming, Jenny, you already pointed out, whenever we say patients not responding or having relapse on TOFA, is it a patient who went from 10 twice a day to 5 twice a day, which technically the label still says. I've given that up because I found that almost every one of my patients flare. So just know, though, that if a patient comes in and sees you and they've done well initially, now they're not, just check the dose, because if they're on 5 twice a day, bring them up to 10 twice a day.
Yeah, he was still on the 10 twice a day. But yeah, that is something that I've encountered as well. As much as we would like to try to decrease the dose, it does in a good proportion of patients who've been so refractory to other treatments. I have also had the same experience.
If I can just interrupt for a second, almost all of our patients with distal colitis we have on something topical, at least till they get well. Miguel and I years ago wrote some type of guidelines for this. We generally prefer not to use hydrocortisone unless you have to short term. Mesalamine comes in enema and suppositories, and now there's a budesonide foam. The brand name, is Ulcerative foam, because if you go to ulcerativfoam.com, at least there used to be a copay card, very helpful. And we use it even inpatient. It's very easy to hold. The steroid impact is far less than a hydrocortisone enema. Hydrocortisone enema is you're basically putting the patient on 10 milligrams of prednisone systemically a day. That's from the manufacturer's studies years ago. So the foam is much easier to use twice a day for 2 weeks and then once a day for 4 weeks.
Okay, yeah. So would you ever consider combination treatment, like adding
What do you mean?
Natalizumab to somebody with some, so this patient's a little bit of a milder case, but keeping the Tacro on board, keeping the Tofa on board.
Yeah, so again, now we're really getting an uncharted area, and I think for the audience, you have to be careful with what we're about to discuss, is the combination of advanced therapies. And by the way, when I use advanced therapies, that's the monoclonal antibody biologics and the oral small molecules, so it's either one. I have had patients on Tofa and Vito. Again, my 6-month rule is, one, will the insurance pay for it? So let's get that out of the way. 2 is I don't want to continue them beyond 6 months if I can avoid it. Would Vito with Tofa probably be safe? Probably yes. We don't know though. Would it add anything? He failed it already. I don't know. I don't think Tofa is one. I don't mess around with too many other combinations. I guess if the guy is at this point adamant against surgery, which again would be his next step, you could consider it, but I'd be a little bit reluctant to go that route.
Yeah. So this is for Dr. Kwan. This is a patient who's had 3 or more treatment options. He's, unfortunately, he's not that symptomatic, but it is something that is not, it's very refractory. So how do you discuss surgical management in a patient like this? Is this something that, how would you approach this patient if he came to see you?
Well, I think I try to probe their understanding of your understanding. So I think sometimes the patient doesn't really see what you're seeing in how they're not responding to the treatment. And I think that's critical, particularly when they're admitted to the hospital. So for this type of patient who gets admitted to the hospital, I would not see a lot of inpatient medical options for him. And in those situations, we want to try and get going with the surgery so they're not languishing on steroids, high-dose steroids in the hospital. So that's the kind of approach I have, obviously counseling them about what the surgery entails and long-term outcomes with the reconstructive options, and those complications. If they are not aware of those, they need to be made aware.
Yeah. All right, so we'll see. So take-home points, we still encourage a treat-to-target approach, the same thing that we've been talking about all throughout this conference. It's important. Close monitoring with fecal calprotectin is important with for UC, I think it's more helpful, not just the resolution of symptoms. And despite best efforts, there may be a therapeutic ceiling with our treatments, but it's important to have ongoing discussions with the patient about treatment options, risk benefits of making changes in therapies. And sometimes therapeutic drug monitoring may help in determining potential causes of treatment limitations. So let's go on to our second case, and then we can hopefully have some time for questions. This is a 49-year-old male. He has a history of primary sclerosing cholangitis, indeterminate colitis, diagnosed in 1996. So he had basically failed numerous therapies, and in the end of the day ended up having a colonoscopy that showed low-grade dysplastic lesion that could not be resected, and had a total proctocolectomy in the summer of 2018 and a 2-stage J-pouch with an ileostomy takedown in early 2019. And in his path report, he had 2 sessile polypoid areas of dysplasia, predominantly low-grade with 1 focally high-grade. And he actually had one of those, really is freaky, had a focal invasive adenocarcinoma in the area of the polypoid dysplasia.
Where was that?
I'm sorry,
Where in the
transverse. I'm sorry?
Transverse colon?
Yeah. So he had transmural chronic inflammation. He had a little bit of chronic active ileitis noted with focal ulceration. So there was a question of Crohn's, but this was reviewed at pathology conferences and was deemed to be more of that PSC type indeterminate colitis and not Crohn's. So I wanted to ask Dr. Kwan, I think these patients are incredibly challenging after the pouch creation. You know, you'd expect them to be better. They expect to be better, but there is a big transition period. How do you talk to patients about that postoperative period? How long does it take to adjust to the changes after ileostomy takedown?
Well, just going back to the case, I think it's important when you find an adenocarcinoma incidentally, it's key to find out how many lymph nodes were examined and refer them to an oncologist. So just to make sure they've had cancer staging and appropriate treatment. But with regard to your question, you know, surprisingly, I think after ileostomy takedown, patients adjust to their J-pouch rather quickly, meaning if they're going to have ultimately a good outcome with their function, that manifests within probably 1 to 2 months. So I think if they're not doing well after a month, I get concerned that they are going to have longer term issues with whatever their issue, you know, bowel frequency typically is the most common issue, or incontinence. The other thing is I've observed that if you when they have the ileostomy up, if you look at their output and it's quite thick, I think those patients are less likely to have problems with their pouch function if their small bowel seems to just inherently adapt to the lack of the colon.
And what would you want us as gastroenterologists to do during this perioperative period, you know, in order to help with that counseling?
Well, I mean, it's always helpful if they're able to go and see you. I think that would be the first step.
Okay.
Yeah.
Sounds good. So with his PSC diagnosis and pathology report, does this affect your post-operative management and the way you perceive things, Dr. Cohen?
Well, so this is a little interesting. First of all, the reason why his colitis may be indeterminate is because the PSC colitis patients are different than the true ulcerative colitis patients. They actually may have a little rectal sparing. They actually may have a little ileitis. So it's probably a different variant of colitis, so I'm not surprised by any of that. The second thing is that he had a two-stage J-pouch. The second stage was creating of the J-pouch?
The second stage was created.
So,
he had a three-stage,
oh, he did have three?
He had three.
Okay.
No.
So one of the things to consider, some surgeons such as ours, patients who have PSC or any patient with ulcerative colitis who have dysplasia or colon cancer, they prefer, if possible, to do a hand-sewn J-pouch so there's no cuff of rectal tissue, because particularly in a PSC patient, you're concerned that that little cuff is going to be vulnerable to getting dysplasia and cancer. And I've actually seen that happen in PSC patients who had cancer later on get a cancer of the cuff. So if possible, we prefer a hand sewn rather than stapled. I know it's not surgeon here, not everyone does that. Subsequently, while this data was not in PSC, since PSC patients almost universally get pouchitis, I actually put them on, sorry to be commercial, VSL number 3, the packets, because that's been shown to prevent first episodes of pouchitis in UC. It wasn't a PSC study, and they're more likely to get it.
Yeah. So he did have a hand-sewn anastomosis, and we did have him he started a Visbiome VSL number 3 pretty soon after. What's the optimal time to scope a patient after pouch creation? I guess Dr. Kwan, Dr. Limkikai, when is the best time to take a look again? Or do you just wait until they're symptomatic with something?
Given his background of PSC and also the increased risk of developing pouchitis and potentially even cancer down the road, I'm fairly more aggressive in scoping patients with the PSC diagnosis even after pouch creation. So I'd say sometime within the 6 to 12 month time frame after that, and beyond that, potentially after every year, and depending on what is found at the time, and if hypothetically everything looks good after a few years, and one could actually try to negotiate stretching out the interval between the pouchoscopies.
Okay. So for 4 months after ileostomy takedown, he's having about 8 to 12 bowel movements a day, 1 to 2 nocturnal awakenings. He's pretty unhappy. He's having difficulty sleeping. He tries taking diphenoxylate, atropine 2 tablets, loperamide 2 tablets twice a day. Maybe he'll have about 6 to 8 bowel movements now with 1 to 2 nocturnal awakenings. He experiences nocturnal seepage. This is where I think a multidisciplinary team is really helpful, and he's seeking dietary counseling. He doesn't really know how to eat. He doesn't really know how to adjust emotionally to all these new symptoms. And he does not want to increase his antidiarrheal medications because he feels that he gets very bloated. So he's eating a low carbohydrate diet, but then I think he gets more diarrhea when he does that. But he takes VSL number 3 twice a day. And for 4 months after the surgery, then he starts now at this juncture, he tries Cipro 500 milligrams twice a day for 14 days with immediate improvement. The recurrence of frequent stools and nocturnal awakenings occur when he stops the Cipro. Then he tries metronidazole, Cipro, switching all these different antibiotics, and basically the only one that really works is ciprofloxacin. Have you guys experienced the same? Have you seen that too?
Yeah, and maybe in a minute you'll get into it, but vancomycin might play a role in PSC pouchitis.
Oh, yeah, okay. And so he's had a C. diff check negative, but he hasn't tried the vancomycin yet. But he does have symptoms recur when he's off of antibiotics. So 8 months after surgery, he remains on the Cipro 500 twice a day with VSL number 3 daily, nocturnal seepage, 6 bowel movements a day, unable to gain weight. He's very worried about chronic Cipro use. He's not comfortable. So what is this? Is this chronic antibiotic dependent pouchitis, or is he a antibiotic refractory pouchitis? How would you characterize this patient?
Yeah, so these patients, he has IBD. So this is an immune-mediated pouchitis patient. This is somebody that you're probably going to want to scope. Russ said it already, the PSC patients are different. These are the patients that we're going to vancomycin a lot earlier in these patients. We're going to Natalizumab, although he had been on it preoperatively a lot earlier. Mm-hmm. This is something I actually wonder, and we're starting to flirt with Ozanimod for some of these patients. But I would scope them, in the 3 parts of the pouch that you want to look at are the anal transition zone, where the anastomosis has been created, the pouch itself, and then the ileum, the pre-ileal pouch. And it's important just to ensure that he doesn't have true Crohn's. A lot of times these patients have inflammation. I don't know what inflammation of the pouch is. I don't know if it's Crohn's. I don't know if it's pouchitis. Clearly he's not responding to antibiotics, so it's not just microbiome driven. Jenny, the only thing I probably would have done earlier is I probably would have used vancomycin. Mm-hmm. We are using that. So the PSC data in vancomycin is pretty good, and pouchitis actually seems to respond as well. So that's one little trick to keep in mind is vancomycin 125 milligram 4 times a day. We've gone higher, but we generally give what we give for C. diff. I give 2 weeks, see what their response is, and then I use vancomycin the same way as I would with Cipro. I have a number of my PSC pouch patients on 125 twice a day as vanco as a maintenance because I can't get them off, but they're much better. If that fails and they have inflammation, I don't think you've taken away their immune system. So now we're getting back to what biologic therapy. The very upfront discussion though with these patients is, would you prefer living with a permanent Brook or permanent endoleostomy, which may be the right way to go, but in a young patient, that may be the resistance. So you're going to now work through the biologic combinations. So vanco, he's been on Vito. You could try it again if he has inflammation of the pouch. Ozanimod I've started to use for some of my pouch patients like this who have PSC. And then you have the opening to all the other biologic therapies.
Okay,
But
that's really...
you should look and see what's going on.
Yeah. So he gets that done. So he has a pouchoscopy. The cuff actually doesn't look bad, or whatever his anal transition zone. His distal pouch and the proximal pouch do have scattered ulcerations throughout, edema, erythema, friability, but the pre-pouch ileum looks normal. So these are the areas that Dr. Regueiro has mentioned that we should be looking at when we do our pouchoscopies. So he has his biopsies show that mild chronic active enteritis on all biopsies, no dysplasia. I just checked a calprotectin. I was curious. It was high, 968 on him. So what do you think? What do you want to do for him? So it sounds like vancomycin would be a good option. Now, patients I've had have not really loved the idea of chronic antibiotics. I don't know if you're experiencing that
But
same
you have
issue.
to educate them. You
Yeah.
have to say that the problem in let's pretend in a PSC. The problem with pouchitis is that the pouch gets irritated by the stool, and while the probiotics sound wonderful, they don't really work. But antibiotics do. Most patients just need 1 or 2 courses of ciprofloxacin or metronidazole or perhaps vancomycin, maybe their whole life, whatever. And it goes away. It's a 2-week course, very standard. But some patients feel great when they're on the antibiotics and horrible when they're off. And I actually like to scope them on the antibiotic to see if despite the antibiotics, how much inflammation do they have. And if they have inflammation, particularly if you're going up into the pre-pouch ileum, if there's bite ulcerations and stellate ulcerations, we call that Crohn's, because it probably is, and then go from there. And then you add to the antibiotics, whatever the drugs that Miguel mentioned, which I all agree with, and then see how they do from there.
So you're okay with chronic Cipro for years on it?
You have to be.
For patients, yeah. Okay.
Probably more comfortable with chronic vanco.
Okay, yeah.
Than Cipro. And
you
Cipro, you
can
just
get
have
it,
to
but
look out for
yeah.
the tendons. Yeah, the other
Insurance
trick
is
with
difficult.
Cipro is the IV formulation you give in the hospital. Most of your patients in the hospital get liquid vancomycin. You may or may not know that, except they'll tell you how much they hate the way it tastes, and you're like, I don't understand because it's a pill, and they're like, no, I'm taking a liquid. Right. Liquid is pennies. It's extremely cheap, so you can have the pharmacies distribute the liquid. It's also now generic, so it's actually, most of the time, it's pretty easy to get vancomycin, unlike before.
Okay. Well, okay, so this is what happened. He tried a trial of budesonide, actually felt much better with the budesonide while on the Cipro. So that was a test just to see if he was going to respond to kind of an immune-mediated type of therapy. No nocturnal seepage, 4 to 5 bowel minutes a day, less urgency. So we actually, maybe because he had been on vedolizumab before, we initiated ustekinumab and tapered off the budesonide, and he remains on Cipro 500 milligrams once a day. He can't seem to still come off, but he feels much better. So would you have considered ustekinumab for him? That would be one question I have for you. And should we be considering biologic treatment earlier for these chronic pouchitis patients with PSC? Is this something we need to be thinking about? As far as how his course goes, he actually has been doing much better. His calprotectin went way down. He can't stop the Cipro, but he has 4 bowel movements a day. He has gained weight finally. He hasn't scheduled his pouchoscopy yet, so we're going to be seeing how that looks. But yeah, I wanted to ask your opinions on that.
So he says he wants to stop the Cipro. I'm like, your Rams won the Super Bowl. Isn't that great?
Okay.
What does that
So
mean?
diversion. Diversion.
He apparently needs to stay on once a day, and he's fine. 4 to 5 bowels a day. I mean, that's pouch. What do you tell your pouch patients to expect when
Cohen.
you do a pouch?
Six bowel movements a day and 1
Right.
at night.
Yeah, and he's
Right.
4 to 5
He's
and none
good.
at night.
He's good. He's good.
And they won the Super Bowl. He got everything going for him. Don't mess with it.
All right, wonderful. All right, so our take-home points for this case: patients with PSC will have greater risk of chronic pouchitis and will need to consider more active management after colectomy, likely. For chronic active refractory pouchitis, we can consider biologic agents to improve inflammation and symptoms. I think it's important for these patients transitioning to have a multidisciplinary team approach with dietitians, psychologists, physician would be ideal. And this is where we're going to transition to Dr. Regueiro, and he'll be talking about his model, medical home, medical neighborhood, and IBD.
Great, thanks. Thanks, Jenny, and as always, a great case. So now for something entirely new, we're going to talk about new models of care. So this has nothing to do with specifically biologic or advanced therapies, except it's interesting, we're actually considering this model of care combining with some of our traditional advanced therapies and seeing if we can establish better outcomes. So for most of you in the audience, you wonder, what's a patient-centered medical home? This is something that's been around for a while for PCPs and primary care, as well as pediatricians. We're looking at this medical neighborhood concept, and I'd like to just simply pause on this slide for a second. I think this may be where we're headed in the future for chronic care models, IBD being one of them. Insurance companies are very interested in these models. Tiered networks are interested. In California, where you have many, many providers, this is something that more and more is coming into play. And what this simply means is the medical home is not a brick and mortar place where a patient goes. It's basically wraparound services for your patients that includes dietitians, psychologists, surgeons, gastroenterologists, but linking also to technology. Because the bottom line is most of you in the audience and practice outside of an academic center, you're not going to be able to do a medical home, or you'll do components of it, but you can't do the whole thing. And the question now is, will we work in these medical neighborhoods? We're starting to do this as a pilot in Cleveland, where I'm working with remote physicians, gastroenterologists in different parts of Ohio. I still have a Pennsylvania license, so also in Pennsylvania, working with them remotely, having our medical home team involved, and having this more done virtually. So where are we today? Most IBD care doesn't occur at UCLA or Cleveland Clinic or Chicago or tertiary center. It's included in the community. It's regionally provided. And I think we're also in an area where disruptive technology is really accelerated by the COVID pandemic. And these new models of care and population health, which you've been hearing for cardiac diseases and other chronic diseases, are here to stay. So there are two parts to my story, if you will, on the future of IBD care models. And I'll freely admit that this is a time to sit back, relax, and enjoy, because this is not as much evidence-based. This is based on some of the information, I think, and based on other models that are out there. So first part, disruptive technology. Well, let's face it, and unfortunately with our recent events, we truly are living in a disrupted world, not only with COVID, but we're seeing this unfortunately in Eastern Europe as well. Let's think about for a minute digital medicine. Some of you and a lot of you in the room probably have more expertise than I, but this is something where the Googles, the IBMs, Amazon are way ahead of us in terms of traditional physicians. This is a way that we might be able to use artificial intelligence. We might even have an Amazon model, if you will, to healthcare as we evolve over time. And I think this is something important to consider. What's telemedicine? Well, all of us now with the pandemic have done telemedicine, and we call it different things, virtual. These are usually two-way videos. That's probably the most common way that all of us are applying telemedicine. Well, let's give some examples of disruptive technology in medicine for a minute. Think about LDL control. This was an interesting study published in JAMA where they used actually remote monitoring in cardiac patients and showed a difference in change, not by seeing the patient personally, but remotely. Same thing was done with mean A1C for actually diabetic patients over time, where they were actually able to show changes in outcomes in diabetics through disruptive technology. Smoking cessation, there are wearable devices and remote monitoring now that have been applied and used to different smoking cessation models very effectively. So these are kind of rapid fire examples of what we would consider disruptive technology. What about IBD? Well, there are a number of studies in IBD, and much of this has actually come out of Europe. The Europeans have been ahead of us, about 20 years of IBD care, looking at these different models of care. There have actually been randomized controlled studies of telemedicine showing improved outcomes in IBD patients, not bringing them into the office, but telemedicine way before COVID. You may be aware of this Health Promise app, Ashish Atreja, but others have actually used this. This is actually now taking off, and different models of this are now being applied where we can actually basically ping, if you will, patients proactively, ask them about symptoms, but in a very simple way. And I was worried that adherence was going to be quite low, but how many of us have your cell phone or your mobile phone out on the table? How many times today have you already checked it? The reality is that patients are used to this. As a caveat, up on the panel, I was getting a lot of texts. I thought it was going to be about my playing, but it's my family's addicted now to Wordle. So Wordle pops up on our apps, and we have a competition. I'm by far way worse than my family, by the way. Most of my family's gotten it at least in 2 tries, if you know what Wordle's about, where usually I'm like 3 to 6 tries. But nonetheless, how many times do you look at your phone every day? It's here, and this is not going away. And if anything, this is going to be accelerated by the pandemic. So this is an interesting cartoon that came from the New Yorker. You can't list your iPhone as your primary care physician. How many of our patients have actually now transitioned where they don't want to come back to the office, and they're quite happy to see you as a specialist virtually, even if they're not seeing their primary care doctor regularly? This is Cleveland Clinic. And this is what the pandemic did to Cleveland Clinic. So kind of the light beige bars are in-person visits in some of our clinics. You don't have to worry about the numbers. But the red arrow was March 17, 2020. And I remember as the chief of GI at Cleveland Clinic, overnight having to switch our clinics to the beige bars to green, which were virtual visits. Now, today in IBD, we're about half and half at Cleveland Clinic, about 50% in person, 50% virtual. Our general gastroenterologists and our community practices are about 95% in person to almost 100%. So we've really reverted back to, I think, pre-COVID, but chronic care diseases have still existed. So that's part 1, disruptive technology. Part 2 are new models of care. So this is something that I put together in Pittsburgh. This is the publication from 2017 on the medical home. We did link up with our insurance company at the time to come up with this new model of care. Well, since that 2017 publication, there have been 357 PubMed IBD medical home publications. And you can see some of the listed names here and some of the difference. And Pediatrics has just published this out of Columbus and Ohio State as well. So these are recent examples of other medical homes. What's the secret sauce? So what's a medical home all about? What's really at the core essence of medical home? 2 very simple concepts. One is we know that the brain plays a large role in our care. And what I mean by that is behavioral health care has to be central to the treatment of chronic care models. It must be. The other part of it is the team. You need a team to take care of these patients, and the team can revolve around a variety of people. So the variety of people includes the primary care, but pharmacists, psychiatrists, psychologists, social worker, dietitians, and you can read off all of the name. So it's kind of the village approach to care. And this is just an example of our IBD medical home team at Cleveland. We've actually added some positions since then, and these are just some pictures. This was a talk we were giving on different gastroenterologists, a nurse practitioner, a dietitian, our nurse coordinators, our psychologist, our scheduler. And what's the difference between a medical home and a center of excellence, what we're used to today when we talk about academic care? So first of all, just look at the first row. What are the collaborations? Well, a traditional IBD center, we work with our hospital system. We're based on RVUs. The specialty medical homes, we're working more directly with payers, commercial entities, so the Bowens, the IBMs, contracting around population health. What's the incentive? Well, for most of us, it's what's the downstream revenue for IBD? IBD doesn't make a lot of money for the gastroenterologist. But surgery, radiology, pathology, that's been the traditional model. Where now the incentive from a payer is how can we improve quality and decrease cost? It's a very different equation. The referrals, traditionally, all of us probably are still used to this, is coming from other providers, primary care, other gastroenterologists. Where now referrals in these medical homes, we just signed a contract with one of the Blues where they're going to start sending us nationwide a large proportion of their IBD patients remotely. We're contracting with the payers. The provider in a traditional sense is a gastroenterologist, where the provider in a medical home are multiple specialists. The focus traditionally for all of us in the room is patient comes in with Crohn's, we look at that. If they have something else outside of the Crohn's, how many times a day do you hear yourself saying, go back to your primary care? Where the medical home is, how can we take care of the whole person? How can we incorporate that into their care? And reimbursement, many of us still work under RVUs. That's a volume-based proposition, where in this new medical home model, it's a value-based proposition. So how did we do for a medical home concept? And I'll just flip through these briefly. Crohn's disease activity index on the far right are most active patients based on a Harvey-Bradshaw score. Far left are patients who have a low Harvey-Bradshaw score. Prior to or at enrollment in the medical home are the dark bars. After enrollment are gray. And what we found were for the highest utilizer, sickest patients, we actually changed their Crohn's disease activity index. For the patients that didn't have that many symptoms, we didn't make a difference. And if anything, I would say they probably don't need a medical home. They're doing just fine not coming into this complex care model. It's really the higher end patients. Unplanned care, which is what the insurance companies want, looking at ER visits and hospitalizations, we're actually able to change this over the course of the first year to 18 months, which is very important to the healthcare insurance companies. So that's it. But wait a minute, all of you are probably sitting there, and in most of my talks, this is what ends up happening when I stopped at that point. I only have 3 more minutes to give you the epilogue. Most of the time it's, I can't do this. I can't do this in my practice. I can't do this in even my academic center. And the question is, 90% plus can't do this. And I agree with you. So the epilogue is, how can we make this work together? So let me give you a brief example of a case, and this is a patient that was referred to us. 45-year-old single female, Crohn's disease, smoked cigarettes, failed 2 anti-TNFs like what we talked about earlier, has active disease, has symptoms, may need surgery, has a huge amount of stress, depressed, poor sleep, finds food, she's overwhelmed with life, and actually she lives in an area where she's 100 miles away from a tertiary care facility. So what are your options? Try to manage yourself, transfer care, second opinion. Probably most of those are what you would choose today, right? But the fourth option is, can you actually get her integrated into a medical neighborhood? So this is kind of the medical neighborhood approach. The question is, starts with the primary care GI, gastroenterologist in the community, refers either telemedicine or in person to this medical home team. Patient comes back to the primary gastroenterologist. APPs are now treating a lot of the patients in the community. And then there's this navigation between the medical home team virtually and the local gastroenterology team. So it's kind of this mix and blended world. So she comes in, she sees the medical home team, and she does have to take 1 day off of work. So that's the downside. But she would have had to do that anyway if it was a second opinion. She meets the entire team, the IBDologist, colorectal surgeon, nurse practitioner, dietitian, psychologist, IBD pharmacist, and a research team. And then she stays connected to the team by telemedicine. So she schedules visits. She actually now sees the psychologist and dietitian more regularly than she sees the gastroenterologist. She sees the gastroenterologist locally because she doesn't really need her biologic treatment change, but she actually now is seeing the medical home team. What are some potential barriers? Well, there are a few. One is there's a limited number of these throughout the United States currently. How do you pay for it? Technology, liability, and certainly state licensing when it comes to virtual visits. Where I think we're headed is that we're in a global payment model now, but we're starting to talk about shared risk and shared savings. I hate to use the C word, but I also think we may be headed towards capitation models when we talk about population health, and we're already starting to do some of these contracts around IBD right now, but this is a population concept. So the upside is we can all work together, and depending on your state, this is something that we're starting to do in Ohio through using technology and through some of the disruptive technology, such that I think the future of care, and that might be today, we're starting to link more and more nationally. We're breaking down barriers, and I think COVID has shown us that we can actually use these models and look at this on a more national level. So where we are in the future, well, precision medicine I didn't really talk about. That's a whole other concept. But I think we're in this medical home environment using disruptive technology, linking together in this medical neighborhood where we're actually able to work with our payers and commercial entities to care for these patients in a way we had not in the past. So thank you very much for your attention. And again, thanks for coming to the UCLA course. It's been great, and I've been honored to be here. Thank you.
Okay, thank you very much. I just wanted to ask the organizers, do we have time for questions, or do you think we should be moving on? Yeah? Okay, we just have a few questions that we just want to address. So this one question is, is this for Dr. Cohen, is there any data for using Ozanimod as a salvage therapy for inpatient severe ulcerative colitis?
So I'm not aware of patients starting Ozanimod alone as inpatient salvage. I do want to point out that at the University of Chicago for severe colitis, we use cyclosporin or tacrolimus, and we bridge them to vedolizumab, so they're on both for a number of months, or ustekinumab now. Mostly we're doing vedolizumab. We used to use azathioprine. And so getting back to the combination therapy thing, we have not found problems with that. It is possible with Ozanimod, although we'd have to be careful because we don't want to give multiple immune suppressants like that.
Right, and then there's been some questions about COVID, if that has changed what patients are on, if that's affected the use of COVID vaccinations. Does that affect whether you consider the vaccination or not, what agent they're on?
No, so the message is vaccinate, 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 independent of the therapy they're on. Even some of the more recent data shows that maybe there's an immunogenicity antibody formation to the vaccine that's lower, but not ineffective. So we must and should not do anything but vaccinate our patients with whatever therapy they're on.
And then currently, the IBD community, what are they saying about fourth vaccine versus not for COVID vaccine? Because that's coming up now.
Right now, with most of our agents does not seem to be recommended. However, if you have a patient who's profoundly immune suppressed on the level of an organ transplant patient or chemotherapy patient, would consider doing that.
Okay. And then last question, have you found that vedolizumab has a slower onset of action versus other drugs?
So it's interesting, if you look at the data as first-line therapy, vedolizumab, it actually works pretty quickly. However, I do get the sense that in our own practices, it may take a little bit longer, but that's also usually because it's not been as much the first-line therapy. If you look truly just at the data itself, the answer is no, it's not any slower. But if I were to be honest, practically in my clinic, I usually tell patients, try to give it 2 to 3 months before we make a decision on switching to something else.
You know, this whole slow thing was our fault. And what I mean by that is that there in the family that vedolizumab is in the anti-integrin, there was a previous agent that most of us don't use anymore called natalizumab for Crohn's disease. And natalizumab was 1 monthly infusion, no load. And in Crohn's, it took about 3 months to work, and all of a sudden it worked really well. So we unfortunately misled people thinking, well, you know, vedolizumab's in the same family. It's a different drug, and there's a load. So ignore the slower story. If they head-to-head against adalimumab and ulcerative colitis, they actually showed that it worked just as fast.
Okay, great. And then the last question here is about PSC. So we talked about PSC in the setting of pouchitis. Now, in the setting of ulcerative colitis, the PSC colitis, are there any unique treatment considerations for that? So I think Dr. Regueiro was hinting at considering vancomycin. So is that something that you routinely are doing in your practice to treat these patients?
So in UC patients without a pouch, not uniformly vancomycin, just for the UC, although it is something that I will sprinkle in occasionally in my ulcerative colitis pouch patients. I think we were intrigued talking about Veto. We were intrigued about Veto, thinking initially it might help the biliary tree of PSC. Studies haven't borne out. I will tell you, if it's not a very severe UC patient with PSC, which most of the time they are more severe, I would consider Veto in that patient, but otherwise I would treat them as I would any other IBD patient.
But it's also important that if you have an ulcerative colitis patient who's had dysplasia or colon cancer, that you do a pouchoscopy every year and biopsy. Those are the patients who get dysplasia. And if they had a stapled anastomosis, make sure you biopsy that rectal cuff. And in the case you had is a PSC patient who had colon cancer. Every year they get a pouchoscopy. The data supporting pouchoscopies for cancer surveillance in any other patient is virtually not there.
Yeah, how often are you doing pouchoscopies for patients without a dysplasia history?
Every 3 years has been the standard for years without any real data supporting that.
Yeah, okay.
Yeah, I agree.
Yeah, me too. All right, I think that's about it. Thank you so much. That was a wonderful session. I really thank all the panelists. This was an excellent discussion. It was a lot of fun. And if you have any further questions, please feel free to come up to any of us. Thank you.